This bill is a comprehensive bill that works with healthcare systems and utilizes flexible, local, interdisciplinary staffing committees and is a unique Minnesota approach to staffing. Over the course of this legislative session, we have met with lawmakers, met with hospital executives, worked with the Minnesota Hospital Association, and made numerous changes to our bill to address their concerns. Thanks to this work, we are proud that our bill has bipartisan support in both chambers of the legislature. But now, at the 11th hour, Mayo Clinic Health System is attempting to ignore the alarming increase in sentinel and reportable healthcare events and the growing list of reports that are showing nurses are leaving our profession in droves. Corporate health executives, like those at the Mayo Clinic, don't want to face the hard truth that it is the unsafe, profit-driven staffing reductions that they are implementing that is causing this staffing crisis. This bill is critically needed, and I pray that when my spouse, my son, my parents, or my neighbors and friends go to the hospital, that they will have the high-quality care that every Minnesotan deserves. Now, I want to introduce some of my colleagues who are here today, including some from the Mayo Clinic Health System, to share with you why this bill is so important and so vitally needed at every hospital in Minnesota, especially Mayo Clinic System hospitals. I also want to especially call out the bravery for the nurses from the Mayo Clinic who are joining us. Mayo Clinic is a health system which has a well-known and checkered past of retaliation and active targeting of those who speak up and union organizers. So I appreciate their bravery in joining us here today. So I'd like to introduce our first speaker, Carrie.
Carrie.
That's all right. Good afternoon. I'm Carrie Wilkemeyer. I work at Mayo Health Systems, Austin. I started my career in 2006. The past 17 years, we have seen things change drastically. It feels more and more like nurses are numbers. We are replaceable, and generally problems can be solved with a pizza party. Needs of the patient come first. That's a philosophy. That's the backbone of any nurse who works the floor. And it's a point where nurses sometimes will put the patients first and safety second, just to make the needs of the patients, to allow for the needs of the patients to be provided. The acuity system that we're currently using, floor managers have instructed the house supervisors to round down when the acuity calls for 7.5, 7.8. They round down to 7. Our acuities are ran at 11. During the day, if you've ever worked the floor, you have morning med pass, baths, meals, wound care, PT, OT, rounding with the provider, dealing with family. And our acuity system is based on charting. In those 3 hours, it's sometimes very difficult to accomplish all those things. So then we are prioritizing care of the patient. Additionally, tasks that are included in the morning, many discharges. Obviously, there's necessary education that has to go with that, and admissions as well. We've had numerous situations where we did not feel staff was provided adequately and care was not provided, and we weren't able to maintain safety. I personally work overnights in Austin, and it's been an eye-opening experience. Seeing how Mayo relies on last-minute jerry-rigging, duct-taping tactics that are not acceptable for nurses and patients. We don't have the resources on site or on call when an emergency arises. We don't have teams, code team, IV team, catheter, transfusion. We have one respiratory therapist. We have one house supervisor, one hospitalist on the floor, and one ER provider. We've had situations with many violent staff. which compromises safety not only for the nursing staff, but also for patients on our floors. Additionally, numerous one-to-ones, and if we don't have staff to provide care for them, we are expected as ICU nurses to respond to any code or rapid resuscitation event. If we don't have enough staff in the unit, we can't provide care for them or elsewhere throughout the hospital. Many challenges we face is knowing there's such a lack of beds available due to the staffing crisis. There are many times when we've taken more than we should, but in the back of our minds, we were hoping and praying and crossing our fingers that we made it to 7:05 when the day staff arrived. And some people wonder why so many people have left the bedside. So we all continue to grin and bear it, but it's not healthy for any of the staff or families, patients. It's getting to be more and more of a safety concern. And ultimately, it's going to be our license on the line if something transpires. We've seen nationwide that nurses are not backed up by their facilities. And I don't know that I want to put my license on the line sometimes, and it's just very unfortunate. And next we've got Julie Lau from Mayo Health Systems, Fairmont.
Thank you, Carrie. And yes, you're right, it is Lowy, but that's fine. I am a Mayo nurse from Fairmont, Minnesota, one of the most west facilities that Mayo does have in Minnesota, just right off of I-90. I have been a nurse in Mayo at Fairmont. I started at the Fairmont Community Hospital at that time in 1998. I raised my children. I went to nursing school and went to the nursing profession when my children were also in school. So for 25 years, I'll be celebrating the silver anniversary in September of 25 years. I also, because of my love for people, for my love for individuals, I also am 22 years a member of the Fairmont Area School Board, and in which I have done a lot of work for the benefit for all of our students. And not necessarily do I commend students just in our district of Fairmont, but I also am a advocate for our neighboring districts as well. We have a lot of students who open enroll back and forth into our district, out of our district, because of the ability that they can. They were given that right by Minnesota education laws, and that is their right. But same as for us as nurses, we have the right to have safe care for our patients. So I look at those two jobs as working hand in hand. As a Fairmont Area School Board member, though, I am an active negotiator for our teachers. I have this is my third round going through the negotiating contract for M&A for Mayo for the M&A contract. And if I was to ever go to a negotiating table with our teachers and feel the way that I feel when I come into a Mayo negotiation seminar session, if I treated the teachers like that, I would be sorely ashamed of myself. I feel undervalued. I many times don't feel respected with our opinions. I don't feel respected for our requests. When we mention that our nurses feel unsafe at times, I feel that it falls on deaf ears. I feel that I could talk till I'm blue in the face, as blue as my uniform, and nobody hears me. And that's not the way it should be. We should be working together, just like I work together with my school board members of Fairmont and for my superintendent, with my teachers, to provide the best education for our students. We have so many opportunities that are given to us. We have a lot of opportunities because we are Mayo nurses. Yes, we do. But what happens to that opportunity when we don't feel valued, when we don't feel respected, when we don't feel that anybody listens to us. Yes, Carrie, you did say that about the staffing. They do staff by charting. Yes, we all know that the numbers come off at 11 o'clock. What is the busiest time of day in the hospital of the day shift? The first 4 hours that you hit the floor. You hit the floor running, doing the 50-yard dash many times just to keep your patients above the standard that you're able to do. These patients that we care for are my friends, my family, my neighbors. I have coworkers that say to me, Julie, you know everybody in our hospital. You know all of our patients. I make it my point to know them. But I wonder if somebody comes to me from Mayo, do they know those people in the beds? Do they know their background? Do they know what they have been through? Fairmont has a low socioeconomical level. Our students are about 50% on the poverty level. Where does that bring our patients as well then? They don't have a lot of resources. Many of them are new to country. They don't speak English. They don't speak Spanish. We have a wonderful interpreter system, but we don't have face-to-face people that can come in and do that interpretations for them so that they have the right. They're better off probably from the country that they came from, yes. And they're very fortunate to come with us. And because we care. We care deeply for our patients, whether they speak English or not. They are just as close to me as my family when I take care of them that day. But it hurts me dearly when I don't have the time to spend with them. That I don't have the time for somebody to get to know them, to listen to them, to hear what their background is. Some of these people come from war-torn areas of countries. We are so fortunate in the United States. We've been blessed. We all know that we have been given so many more rights that some of these people from these other countries can only dream about. So let's not dream for just what we can do, or dream and hope that we can make it to 7:05. And whether there's 7:05 a.m. or 7:05 p.m., the first 4 hours of any shift, I work both shifts. I work days, I work nights. I work weekdays, I work weekends, I work holidays. I work in a hospital. I know I can work 7 days of a work week. I choose my shifts to work. Yes, I do choose my shifts. But I choose to work in a hospital. I love the work that I do. I love caring for my neighbors, for my family, for my friends, and for my students in Fairmont. They are all near and dear to me. And like I said, I am here for everyone, whether it's in the school area, like I told you that I work for. And I tell you, I work for the school district. I'm basically a paid volunteer, but I do earn my wages from Mayo, and I am very appreciative of that job that I have. I wouldn't be what I am today if it wasn't what Mayo gave me. Yes, that is true. But what we're here today is to make sure we have safe care for every patient. I have nurses who run continuously all day. We have the ability that they can fill out unsafe staffing. When are they to do that? Tell me. When they've run a 50-yard dash for 12 hours of their shift, when can they do that? They got to finish their charting. Sometimes that charting doesn't get finished till 7:05 p.m. or doesn't get started until 7:05 a.m. after their shift. And guess what? When they finish that, My bed calls me after a 12-hour shift. There's no time to do that. I get called many times. I'm a 25-year employee of Mayo. If you look at my seniority hours worked, it's the equivalent of about 28 years that I've been there because I have worked a lot of overtime. Yes, some of that was my choice. Some of that is the choice that I made because of my coworkers. Because I can look at my phone, see the schedule, and I know who's working in that area. And I can only guess sometimes what their day is like. So when the text comes out that they need support, need help, yes, I come in, I help. Who tells me thank you? Who appreciates when I come in? My coworkers. Why do I come in? My coworkers. Because I want to help them. But then again, too, I want to help the patients. I want those families to go home and know that their family member is taken care of. That somebody has deeply been involved in their care and that they have heard their concerns and that they're listening to them. Because sometimes it isn't the labs that are run in the morning that shows what's wrong with the patient. It's not the MRIs or the CTs. Sometimes it's just knowing what's in the patient's heart or in their background. That when somebody has that time to sit down and visit with them a little bit, that sometimes we can crack through into their background and help them a little bit more and maybe work with the labs or the testing that we have to do. I'm sorry, I am just going on and on, but I can tell you how much I love this job. I love the job that I have in the school district as well. But I see nurses choosing not to return. We have to work together to keep us going. We're seeing a shortage of workers all over the United States. It's not only nurses. It's all over. But each thing that we can do, everything that we can do to help make them get up and want to come to work for their day shift or their night shift, to make an impression in that patient's life is what we can do. I could go on, like I said, and I thank you so much for your time. I appreciate everything that you do, and I then also would like to introduce for you our next speaker, who is Becky Nelson. She is a registered nurse from Abbott Northwest. She is our M&A partial of our chair. So welcome, Becky. Thank you. Thank you so much.
Good afternoon, everyone. I'm Becky Nelson. I'm a little bit disappointed that I have to be up here again defending this bill. I'm a registered nurse, and I'm currently working at Abbott Northwestern Hospital in peri anesthesia. I'm the chair of M&A's Governmental Affairs Commission. My first job in nursing was at Mayo, St. Mary's Hospital in Rochester. That was in 2001. It was really the first place where I learned how to actually be a nurse in that critical first year out of nursing school. But even at that point, many years ago now, I could see signs that Mayo had difficulty recruiting and retaining seasoned staff. After about a year, and I actually think it was less than a year, maybe 9 to 10 months of nursing experience, I was one of the rotating charge nurses on the night shift in my high acuity cardiac surgery step-down unit. So as you heard from these two amazing Mayo nurses here today, those problems really haven't gone away. So I know of many nurses at Mayo with similar stories who are afraid to speak out. Hundreds of them submitted concern for staffing forms in the last year in spite of their workload, with some of those stories described in your handout, like nurses who were told to fill beds even if there were no nurses to staff them, and patients who left emergency rooms without receiving care. It's really not that hard to see why nurses would be intimidated by Mayo when they work closely with the National Right to Work Foundation to spread misinformation about unions and sabotage union activity and decertify Mayo union hospitals, the same tactics that they now want to use against all Minnesotans to hold on to their corporate power and profits. If even our state's highest elected officials are intimidated by Mayo, you can imagine what it's like to work for them. M&A nurses are deeply, deeply concerned that Mayo is seeking to undermine the staffing standards we really need, we desperately need across the state. The patients in Rochester deserve the same staffing protections as every other patient in the state. They deserve to know that when they or their loved ones walk into a hospital, they are going to get the care that they expect and deserve from enough highly skilled professionals. The nurses in Rochester also deserve the peace of mind knowing that their patients will receive timely and appropriate nursing care, even when they have the extremely complex conditions that the Mayo facilities tend to admit or need intense one-on-one care. We, meaning M&A, has made a lot of changes to the Keeping Nurses at the Bedside Act, and we compromised in both the House and the Senate to earn bipartisan support. It is completely unethical for Mayo, a non-profit corporation, to attempt to override democracy and disrupt the legislative process at the last minute with what are essentially blackmail tactics. The tax-exempt Mayo has received hundreds of millions of dollars in public funding. Mayo and our elected leaders must answer to the public and not powerful corporate interests. I'd like to introduce our bill chief author in the Senate, Erin Murphy.
Good afternoon. It is good to be with you. I'm Erin Murphy. I am a registered nurse. I serve in the Minnesota Senate, and I am the bill's author in the Minnesota Senate. It's an issue that I have worked on now for many, many years with the Minnesota Nurses Association. And it's important to note that this proposal is in both omnibus bills in the House and the Senate. We have never, ever seen this bill make it through the process this far, and that is because of a great deal of compromise and leadership on the part of the nurses, Minnesota's nurses, over many, many years to bring us to this position. It is an important piece of legislation, and I want to be crystal clear that I am committed to see it becoming law. When our loved ones are in the hospital, we want them to receive excellent care delivered by skilled Minnesota nurses, and that is the goal of Keeping Nurses at the Bedside. There are really three important provisions that are the power positions in this legislation. One is a strong voice for registered nurses in hospital staffing, planning, and delivery, both the planning and the delivery. There are provisions for conflict resolution and, if necessary, arbitration to make sure that the goal of the legislation is advanced, and that goal being safe staffing, excellent care, and the retention of our registered nurses in the hospitals. And the last is public reporting, so that Minnesotans and policymakers alike have the opportunity to understand how the bill is working and what it means for Minnesotans, for staffing, for retention, and for care delivery. I'm committed to this proposal and committed to making it law. I believe and expect all of our hospitals to participate in this critical effort to improve staffing and to retain our nurses. This is not the first time that a powerful corporation has used its power and ample resources to get their way. It makes people angry, and since Friday, what I've heard a lot from people inside this Capitol and outside of this Capitol is their anger at an ultimatum being delivered in the 11th hour by a powerful and very well-resourced corporation. It's not the first time that a powerful corporation has threatened to leave Minnesota if it doesn't meet their demand. This is incredibly frustrating to me. And to Mayo, I say stay. I say stay and participate and lead. Years ago, Minnesotans committed to Mayo and to Destination Medical Center, a region in the state. We invested richly in that region. A past legislature, including me, decided that investing in the region and in that destination was valuable to the health, to the well-being, and to the future of Minnesotans. And in the same vein, Minnesotans support its nurses because they recognize their value for our health, for our well-being, and for the future of Minnesotans. Minnesotans enjoy a high quality of life. We enjoy a high quality of life because Minnesotans have set for us high expectations. And we meet those high expectations as policymakers and as nurses by setting high standards and meeting those standards. And that is what we're doing with keeping the nurses at the bedside. When we set high standards as policymakers, we invest in Minnesotans. It's why we have clean water. It's why our schools are strong. It's why our communities are vibrant. And it's why all of our hospitals have to be included in this proposal. Because regardless of zip code, your health, your wealth, or your well-being, you deserve to get high quality, excellent care by skilled, professional Minnesota nurses in every hospital in the state of Minnesota. And to say some are in and some are out is a disservice to the well-being of Minnesotans across the state, and that's no good. And that's why we're going to pass this bill. And next, my colleague, Sandra Feist.
Hello, everyone. I am the chief house author of the Keeping Nurses at the Bedside Act, and I would like to share with you a little bit about process around this bill. You've heard from our nurses and from Senator Murphy why this bill is so critically important to patients in Minnesota. And I would like to talk about the underlying bill, that it is a compromise bill, as you have heard. I am a lawyer when I'm not in the legislature, and I and the nurses and Senator Murphy have worked very tirelessly. You okay? We're just going to take a moment. Cool. So I and the nurses and Senator Murphy have worked tirelessly with hospital stakeholders. I have had countless meetings with the Minnesota Hospital Association, with Mayo Clinic, with individual chief nurse officers and CEOs of hospitals from large to small across the state of Minnesota. And we have heard their input, and we have worked very hard to incorporate it into this bill. This is a compromise bill. It is a well thought out, reasonable bill that will keep nurses at the bedside and make sure that all patients across Minnesota are safe. 8 other states have staffing committees written into law. One of those is moving to a more strict ratio system, and 2 other states already have strict ratios in law. So this bill is an approach that has been taken across the country. And we, as you heard, are taking our Minnesota-specific approach to staffing legislation here with the Keeping Nurses at the Bedside Act. Mayo should be part of the solution and not try to undermine our bill. We worked with them extensively, and all of a sudden we were very surprised to hear their demands, as you've heard at the 11th hour, saying that they wanted to be fully exempt from our bill. We are open to working with everyone, including Mayo Clinic, on a solution that ensures that this bill achieves its goals, that it protects patient care, that it keeps nurses at the bedside, and that it ensures that every patient across Minnesota has that same access. So we are committed to working with anyone who will work with us in good faith to find a solution and a path forward that achieves everyone's goals. Mayo talks a lot about how they provide exceptional patient care, and this bill would provide them an opportunity to share with other hospitals and with the state of Minnesota what that care looks like in raw data. And we don't really understand why, if they believe that their care is so top of the line, so exceptional, why they wouldn't want to share that with other hospitals to ensure that all hospitals in Minnesota could learn from their example and their expertise. Any compromise that we would enter into would have to achieve these bill's goals, and they cannot include the language that Mayo Clinic has proposed that would gut this bill, that would exempt every single hospital in Minnesota from our bill. That is not an option. And I would like to end with a message from a Mayo nurse that I received this morning. She said, "Please tell the legislators to pass the Keeping Nurses at the Bedside Act. We need relief, and Mayo is not listening to us." Thank you all for being here today. We are happy to answer your questions. This is an incredibly important piece of legislation. And I'm the last speaker, so I think I'm the last speaker. So yeah, we'll open it up to questions. Thank you.
Chris, first, can you kind of just explain to what extent the MMA is involved with Mayo and its satellite agencies throughout the state?
Yeah, so the Minnesota Nurses Association represents Mayo facilities, including some of those that had nurses who spoke here with us today. But of course, we also work with nurses from across the state, from union facilities and non-union facilities. And, as Becky said, she is in contact. We all are in contact with nurses at Mayo facilities who are concerned that their employer seems to think that they can run the table or take their ball and go home if they don't like the will of the people of the state of Minnesota.
How closely do the provisions in keeping nurses at the bedside act align with some of the contracts that were struck after last year's contract negotiation strike?
Mm-hmm. Yeah, so the language that many of our facilities who were in the negotiation process last year gave nurses a significant increase in voice at the table with our employers. The key difference is that this legislation has enforcement mechanisms. It's very difficult to get a large hospital like my own employer or the Mayo Clinic System to follow the rules. It's just, I'll be quite honest, they have a lot of money and a lot of power. And so this bill allows our partners at the legislature and the Department of Health to be that enforcement mechanism and make sure that patients are protected.
Can someone speak to maybe Representative Price? You specifically mentioned how their amendment is inadequate. Is it because it just at its core doesn't require the makeup of the committees to be as described? Because I see they list a bunch of conditions by which you could be exempted if you met X, Y, Z. Are X, Y, Z insufficient and why?
Yeah, thanks for the question. So Mayo has provided two proposals at this point. The one that you're talking about, I assume, is the one that's public. And that had three mechanisms by which a hospital could be exempt. The first was magnet hospitals, and that is a very opaque system. As far as we can tell, if you pay for it, you can be a magnet hospital. So that was a no-go. The other was critical access hospitals. We work very hard with critical access hospitals across the state of Minnesota to create accommodations for them. And in fact, those accommodations are in the process of being expanded for all hospitals. Over 50% of hospitals in Minnesota are critical access hospitals. So right there, that would be over half of the hospitals. The third mechanism would be if a hospital has a certain type of acuity tool. The description in this proposal is every acuity tool. So that would be all the hospitals. And that is the problem with the second proposal as well.
So they've come back with some changes to that initial proposal.
So they took out magnet, they took out critical access hospitals, and then they added in all of the things that they're already legally required to do as their annual attestation in order to be exempt from this law. But they're already, and all hospitals are already required to do those things.
And the last thing I will share is that they shared with us that they would want their board of governors to attest to their plan. And then if they have violated any of the provisions of their plan, then their board of governors would report on themselves to the Department of Health, which is not a very transparent system. And it is one that is not very nurse-centric or nurse-focused. I know the role of governing. I've served on a board of directors. I know what it is to take care of a patient. There are different things, and I want to make sure our skilled professional nurses are informing the staffing plans, and they are not just attesting, but they have committed to not just the execution of the plan, but to the planning itself, and that is a part of whatever is in our law, in our bill. It is that it is a part of every plan, every committee, that the nurses together with the hospital administrators are creating that plan, and they're executing that plan. And if there is any deviation from that, then those provisions need to remain intact. And right now, what Mayo's proposing doesn't get anywhere near that.
Did you guys have the support of some of the senators that came out, or in the House of Representatives too, in support of Mayo's comments after they were made. Do you guys have the support of those lawmakers before those comments were made public? And if so, did something kind of change with their perception of things? I'm specifically thinking if Senator Nelson came out and said, this is raising the alarm bell. We need to listen to the Mayo Clinic. You guys mentioned bipartisan legislature.
In the Minnesota Senate, Senator Jim Abler is a co-author. He's on the conference committee. He supported this legislation for many, many years. Senator Nelson has not supported this legislation. But as I have spoken with my colleagues, and of course, we have moved this all the way through the Senate with a majority of votes. That's why it's in the conference report. Their perspectives have not changed, including my colleague, Leader Dietzig.
Senator, could you discuss the role of arbitration and why that was important in this bill? I ask because some of the most recent states that took the step, they ultimately left it back to the hospital executives if there was an mess. In fact, I haven't found a state yet that would have arbitration, and I've looked at them all, so maybe I'm wrong. But why are you taking this step? Because that's something that other states have not done.
So the important thing about the structure of this bill is that nurses have a meaningful voice. And the challenge is that in states where they have had the chief nurse officer be the tiebreaker, that essentially means management is a tiebreaker, and that is the status quo. So the point of the bill is not arbitration. The point of the bill is to have a third party, neutral, objective decision maker if there is an inability to get to consensus. But the hope is that this collaborative body would be able to get to consensus. And many of the hospitals that we've spoken with have actually had very similar committee structures with meaningful nurse voice. So what we're describing is something that already exists in a number of hospitals that we've spoken with.
Yeah, I wondered if you could describe what you think that process will be like. Is it going to be like a union negotiation saying, we want 20% more nurses and you end up with 10 in arbitration? Or is this going to be more of a collaborative process? Maybe what some of the nurses or someone can speak to how they envision the process going.
What I think is important, and I've been talking with my colleagues about this a lot. We are in a building right now that requires people who disagree to sit down together and find a path forward for Minnesotans. And what we're essentially doing is asking hospital executives and nurses, professional skilled nurses, to do the same thing around the delivery of professional nursing care. They are the experts, not the people doing the math on the grid. It is the professional nurses who are the experts, and they're giving themselves a 35% vote. 35%, not a majority. They are the experts giving themselves a 35% vote. We need a powerful tool. We include conflict resolution, but we need a powerful tool of arbitration if we still get to impasse. And our experience over the last nearly 2 decades on this is we get to impasse on this issue over and over and over again. So there's got to be a powerful tool. And hopefully that powerful tool propels us forward to the place that we want to be as professional nurses in our hospitals, so that nurses want to practice nursing there and take care of patients. We want that. I want that as a policymaker for the people who are getting care in our hospitals.
Senator Murphy or Lieutenant Price, this is a lot about the keeping nurses in the bedside act, but they want the healthcare affordability board just out off the table. I know that's part of the omnibus bill and negotiations. Do either of you have a thought about that, and or is this just the main focus of what you guys are pushing for at this point?
I will just say, as a member of the Minnesota Senate, it would be amazing but not realistic that I would have the kind of power to say at the end, I don't want that anymore, and it comes out of a bill just like that. Right? I struggle with that a lot. This is a democratic decision-making body. And when an organization or corporation uses its power to knock something out in consideration by the legislature, I think it's an overreach on my perspective. That's my point of view. And I don't know if you want to talk a little bit more about the board. I know is Liz Ryer's proposal.
Yeah, I was just going to mention that seems to be going down a more collaborative, productive path.
The healthcare affordability.
Yes.
Provision.
Yeah.
To what extent is Mayo involved in kind of crafting this bill? My understanding is that they had seen this, say, prior to these comments after the light.
I was going to do visual aid, but this is not a visual medium. I just have in my backpack. So we have been talking with Mayo for a very long time. And if you look at my notes, you will see that they had a lot of input. They talked about antitrust law, indemnification, liability, like accreditation and federal regulatory obligations that hospital executives have. And we worked very closely with them to weave a lot of their input into this bill. And the exemption was one of 800 million ideas that they had that we were in good faith working through very systematically. As I mentioned, I'm a lawyer, and that's kind of how I roll. So I really enjoy those details. So they, we were taking in their input. It is part of the fabric of this bill already.
When they threatened to pull that funding, were you guys surprised when you found out about that?
Yes, that was a surprise. We thought we were working together in good faith in a collaborative manner to make sure that this bill was a workable bill for hospital stakeholders. And we thought that that was what we were doing. And I guess we were wrong.
The Mayo is, it's got a reputation of caregiving. It's why they are, for so many people, a trusted destination, not just Minnesotans, but people from around the world. That's why we want them to stay. We want them to stay and participate and lead, not walk away. We will all be enriched, and care will be better if all of our hospitals, and I will say, when I think about the nurses that are working in small community hospitals, regional centers, big hospitals, those hospitals are doing important work for the people in their communities. They're all important, and they should all be treated equitably, including Mayo.
If I may ask, right now there are about 30% of Minnesota's hospitals are considered financially distressed, which means they're in trouble. Included on that list is Mayo Fairmont and Mayo Austin St. Ed. Not Mayo Springfield anymore because they closed. But my question is there any concern that the more of these this is a comprehensive health reform bill and it puts a lot on their shoulders. Are you concerned that you're going to keep pushing them to the point they close the doors? Because fewer nursing jobs is not necessarily better.
Yeah. So there are actually studies that show that in states that have staffing committees or ratios, that this actually saves hospitals money because we know that safe staffing directly ties to patient outcomes. And so if we are reducing adverse events, then we are saving hospitals money.
So if I can just add a point. So I'm a cardiac nurse, and under Medicare reimbursement rates, if I discharge a patient home who's had a recent hospital admission with, say, heart failure, and we send them home, and for whatever reason, they're not able to access their meds. I wasn't able to fully educate them on taking those meds, going to follow-up appointments. If that patient comes back to the hospital within 30 days or less, the hospital doesn't get full reimbursement for that next admission. So the patients are suffering, and the hospital is losing money. We are trying to work with the hospitals for the betterment of the patients and to preserve their financial position. These things go hand in hand, and I don't understand why they are seeing patient outcomes and patient safety as divested from their bottom line. Their bottom line is patient safety and community health. That is the bottom line.
And I think, Chris, to your point, when you don't have time.
Can you introduce yourself?
Sure. Carrie Martrud, nurse staffing specialist with the Minnesota Nurses Association, CARRIEMORTRUD. I think what Chris and all the nurses are trying to get across is that when nurses don't have enough time to assess, talk with patients, do skin assessments, they miss those little things. I just watched a clip this morning from CBS where a reporter talked about failure to rescue. So the fact that there is a term in healthcare called failure to rescue should be startling to everyone. When nurses don't have time to spend with patients, serious symptoms slip through the cracks and they suffer, and very bad things can happen very quickly. And what nurses are asking for right now is that we are not just input, but we help decide what the staffing looks like so that you're not relying on last minute expensive overtime, which is part of the cost problem. If you have empty holes in your schedule and you are filling them with time and a half and double time because you don't have enough staff, that costs you more money. So and travelers, all the nurses are asking for is to be part of the process and decision making at the beginning, so we are prepared for those day-to-day shifts, that then the acuity tools can also help determine what the staffing is. There's been a soundbite that this is going back decades. It's archaic. It's ridiculous to think that we go back to a time where staffing is only talked about quarterly. That is not at all what we are saying. We are saying that nurses need to be part of that proactive planning so that we are not relying on overtime, double time, and exhausted nurses to care for the patients. You all deserve better.
Any other questions?
Can anyone just speak to, it sounds like negotiations or discussions rather are going poorly with Mayo Clinic at this point, but can you guys at all talk about, okay, if their amendment is gutting the whole bill, where would you be willing to pare back some of the requirements to maybe counter offer in a way that's more palatable? Can you at all speak to that?
So our conversations with the Minnesota Hospital Association are ongoing. And so when we talk about what a meaningful voice looks like and what these staffing committees function like, that looks like that is the result of these extensive conversations with hospital stakeholders. What we are talking about with Mayo is not the structure of the bill. They stepped back from the substance of the bill and made an ultimatum that we had to just carve them out. And so that is what those discussions center around.
Great. Thank you, everyone.
Thank you.
Thanks.